Thank you for taking time out of your important work there in Washington, D.C. to join us. Let me reflect a question back to you. I'll just pause for a second and remind everybody, if you do have questions, please put them in the chat. We've been collecting them as we go, and there were a number of great comments and questions, and I'll start with some of them. So to the point of trust, Mr. Patterson, one of the things that's always been impressed on me is that a lot of one of the important elements of trust is sustainability, that, if we provide a service to a community, that we're going to be there for them and that we're not going to leave, whether this is a medical service or other social services or any commitment we make. How do you see this project? Obviously there's a lot that's going into it. There's funding, there's organization. How do you see it sustaining, and what does the future look like with this sort of project in our communities?
I see it sustaining in a couple ways, but it needs to be a connection organizationally and not just individually. Sometimes, you're just fortunate to have a few good individuals that work well together. And then all of a sudden, life changes, situation changes, and they go on to do other things, and the work that was being done no longer gets done. So I think one of the things that you heard both of the doctors really spend a lot of time on was talking about the infrastructure, talking about how we set this up, talking about how we do this so that as people go from one area to other area, the commitment remains. The commitment from the housing authority, the commitment from the medical facilities, the commitment from the educational facility. It has to stay there. That's how you sustain it. And you also sustain it by delivering to the people that you're serving. When they begin to see that you're actually doing the things that you said you were going to do, they will believe in it and they will be more active. And even if you wanted to go, they're not going to let you go, because now you started to do what you're supposed to do. So that's how I guess I'll respond to that.
Thank you very much.
If I may make
go ahead, Sanjay.
Make a comment to what Jeff just said. And I think all the notes that Jeff hit on is exactly, I think, what we need to think about. For us, as we were putting together this proposal, we were a bunch of, mostly academic investigators, but deeply ensconced in the idea that we were tired of doing things just from the perspective of doing something that is non-sustainable. There's just absolutely no reason to do the next proposal that goes out for a couple of years and vanishes. And that's really not at all the spirit of this proposal. The entire spirit of this proposal is, how do you, within the current constraints of health provision, carve out a unique, economically sustainable model that's impactful. And it has to be at all the points that Jeff and Ijeoma so wonderfully made, in terms of, it has to be at the locus of where the patients live. It has to take advantage of models that are inexpensive, and it needs to pay for itself. It needs to provide a mechanism where we can, once we get this on the rails, it's going on, forever, for the long term. And it also needs to take into account all of the information that we already have. We don't need another paper, another, journal saying this or that, but the work needs to be done. We don't need to print brochures, but we actually need to get the work done. So I think that's intrinsic to what Detroit is trying to do. This is a small effort. This is not as if you're going to solve the entire problem, not even by a long shot, but at least it's an attempt with the right kind of emphasis and the right types of issues, and hopefully with the right type of attitudes and the cultural understanding and all of those enormous issues that I need to be educated on, and we need to be brought up to speed. Hopefully with these types of partnerships is the only way to make a step in the right direction.
Thank you, Sanjay. And let me just extend a question on that. As I saw your presentation today and in the slides I've seen previously, this seems almost like a perfect toolkit for a medical care, healthcare organization to have. You have the cultural focus, you have the personal touch with the community health worker, you have the right screening tools and so forth. Again, you know, from a more practical point of view, on the medical side, how can this become reproducible?
I can actually take, oh, okay.
No,
Go ahead.
Guillermo,
please.
go for
Yeah,
it. Guillermo,
Yeah,
go for it.
because this actually ties in with the question around sustainability. So one of the things that we're doing at Wayne Health is that simultaneously we're definitely taxing ourselves and lifting heavy or making heavy lifts. So while we are rolling out this project, we're simultaneously shifting our healthcare delivery model or system at Wayne Health. So the same process, as you said, this protocol or this process of, as folks are coming into the healthcare space, to identify those social determinants. First of all, get everybody trained, right, in terms of cultural humility, in terms of understanding the role of social context and social determinants of health, so that folks are primed to do this work appropriately. And then folks are getting screened, and those needs are identified, and there's a partnership that is built with the patients, and then there's a linkage to community-based resources, and that is warmly done, not just offering a number, but really walking the patient through that process, through that journey, to ensure that the person is linked to that resource, and that resource is actually engaging the patient in a way that makes a difference, you know, in outcomes long term. That is the process we're actually literally transforming ourselves around right now, so that we're doing two things at once. We are certainly in the business of knowledge production, the implementation science of this work, the research pieces, the production of the data and the knowledge, right? But then we're also literally implementing it in real time to impact literally all our patients. So we are showing ourselves as a test case that this is very, very doable. This is not just doable, it's critical. If we are to make any difference in patient outcomes, we have to do things differently, because the former way simply is not working. And then the other piece to this is that the knowledge that is produced is not just going to live in the academic journals, right, where folks can pat themselves on the back and say we've done research, but that they go to inform the decision makers and policymakers, again, because again, where there's no money, where there's no money, there's no mission, right? So that it can, as Sanjay said, pay. You know, this work can pay, you know, for itself when the project is over, that it still keeps going on, because now it's integrated into the payer model system for healthcare, in at least for us in our region.
Thank you for that. I'm going to add in a couple comments that we've seen in the chat regarding the sustainability. You had made mention of this, Dr. Apara, but Ginny Pate points out that the Pathways Hub model brings the sustainability in terms of community health workers. Also, a very interesting comment from Nick Dreyer about looking for, we incorporate business schools and business partners in terms of finding what the ROI is, finding out what the sustainability piece can be. We know, all of us who are on this call, we've been doing this for a long time. We know that it's cheaper to prevent illness than to treat it. That doesn't need to be proved again. The question is, how do we make that journey from where we are to get there? I see that Ms. Burns, who has been adding some delightful comments, important comments in the chat, has her hand up. Ms. Burns, are you able to take yourself off mute?
Yes, can you hear me?
Yes.
Yes.
Good, good. I've been listening to both of the doctors' presentations, and they're very important, but what seems to be overlooked is the spirit. I keep going back to that. I did a presentation with you guys some time back, and my whole focus is on the spirit of people. All this will not ever succeed or get off the ground if you don't start connecting with the people who are you trying to help. You know, oftentimes we miss what's going on health-wise, as far as heart failure, strokes, all of that. It's because the person doesn't feel good in the first place. And I'm not talking about feel good physically. I'm talking about feeling good spiritually. You got to get out here, come out of these high towers, connect with the people whom you are trying to help. How you feeling today? You know you look good. You're beautiful. Has anybody told you today that they love you? This is how you try to connect and make people feel good. Once they start feeling good about themselves, then they're going to be like, you know what? Maybe I should go and have this checked out. Maybe I should do this. But where I live, and I live on a CMHA property, one of Jeffrey Patterson's CMHA property, it's violence. It's people whose spirits are low. It's children who talk about wanting to kill themselves. Why? Because they are unhappy. So let's start digging at the root. Let's start talking to people. If you start talking to one another, then you'll find out more about what's going on with that person, and then things will start to shift. We need to start building on restoration and restoring people's how they feel about themselves in order for them to move out of that space into another positive space.
Marilyn, I commend you for those. Perhaps you get my vote for the most important comment. I could not have said it better than what you just said. Ultimately, I think the work always should be centered around, the individual and how they feel internally, and connecting the internal with the external is part of our work. I could not agree with you more. I for one can tell you that we're not in this to sit in our ivory towers. I think the whole effort is based on connecting. But beyond that, I think each one of us needs to find the ability to connect, and I mean connect with the internal self of all the individuals that we are trying to help. And your comments about low spirit are well taken. I totally understand.
And I'll step in here too to say, Ms. Marilyn, thank you so much for those comments. I think it was Auntie Maya Angelou that said that people don't care how much you know, they care how much you care. And so to your point, absolutely. And that's one of the things that excite us about our mobile health units is that we take that care to the folks where they're at. And present ourselves in the community and out of those ivory towers. So our model is built exactly on what you're offering, and to show people, not just talk about it, but be about it, that ultimately that we care and that people's lives matter and of value, especially the population that we're taking care of who usually gets messages that their lives don't matter, are not of value. So it's absolutely imperative that we counteract that messaging by our work and the ways that we show up where people are at. So I'm really proud of the work that we're doing, and that many of us on our teams live or are close to the community, are from the communities that we serve, or embed ourselves in the community that we serve in the Detroit area. But your point is well taken and needs to always be centered in all of this. It has to be more than just the data. It really does have to connect to the spirit of people.
And I would just add to that too as well. I thank Ms. Burns for her comment and her presence in the community and the role that she plays. Her voice is always heard. Her words are always spoken in a way that you need to hear it. And I think that one of the things that I think is exciting about this initiative is because I think it does some of the things that we're looking for by getting out there in the community and building that trust, building that relationship. I think that was one of the things that made Sanjay reach out, and I'm sure Dr. Opara in Detroit did the same thing in reaching out. That's not traditionally how this type of work had been done, but I think getting out there, bringing people, and now it's just about building that infrastructure and rolling up our sleeves and doing it and asking the questions that you ask, doing the actions that you ask, and then sustaining those actions. So I look forward to it again. And as the doctor said, it is all about those relationships and establishing those relationships.
Thank you all, and thank you, Ms. Marilyn, for your thoughts and your comment, for joining us today. There are couple of questions or comments about more about faith, more and even some about religion, as those two certainly intersect. One question was whether religion had been used as perhaps as a variable in this in looking at the populations who are at risk. The point was made that there have been some communities that over the past, say, 50 years have become more religiously diverse. And the question, have we ever looked at the health outcomes? Has there been a change in health outcomes or disparities in those communities as they become more religiously diverse? And then perhaps linked to a final point and question about, let me just find it. The persons of color are more likely to talk with their faith leaders about health concerns. How can we connect with those faith communities into this model of care?
Let me take the first question. I do think there have been studies previously done that have tried to link whether or not you belong to religious practices or spiritual traditions and generalized health parameters. And there is a relationship between those two outcomes. It's not a perfect relationship by any means stretch, but have there been studies that have, again, examined events over time to see how does change in spiritual and religious practices alter your health outcomes? I'm not aware of any well-done study. It's certainly an interesting, question where connection to some sort of truth that you believe in, whether you can harness that energy in order to translate that into better wellness, which in turn results in better health outcomes, physical health outcomes, is something that's absolutely worthwhile, pursuing. We don't have that formally in our model, but it's certainly something that we are willing and worthwhile, very willing to consider and worthwhile to consider. Ijeoma, do you want to comment on that?
No, I think that you responded excellently. I don't have much more to add.
And there was a second question pertaining to which I think others might be more qualified to answer, quite frankly.
What was that second question?
The second question was about how can we involve faith leaders to be a mode of communication between Black communities and health providers. I'll add a comment from Kristen Creation, who is part of Better Health Partnership, about the COVID response group that we've had here was a terrific link between medical and faith leaders, where a lot of the initial testing followed by vaccinations took place in churches and through linking with our faith community, just as an example.
Yeah, I can speak to that. And I will start with this basic premise, which is that, COVID showed what was possible when we just put red tape and other, frankly, nonsense. I'm sorry, I'm a frank, blunt person, aside, and just came together and worked across sectors and disciplines to save lives. And we truly need that mindset as we move forward. Our healthcare system, frankly, needs a complete overhaul. And we need to increase the funding and the infrastructural support for those cross-collaborative, cross-sectoral, cross-disciplinary, cross-professional collaborations to actually impact health outcomes. So yes, that includes faith leaders, that includes community leaders, that includes payers and clinicians and community health workers and teachers and the criminal justice leaders, and the list goes on. So my passion for this project is the opportunity to at least start the process of reimagining what healthcare can be in order to actually move the needle when it comes to health outcomes. It is not okay that this country, this wonderful country as it is, right, is one of the last in terms of high income countries in the world for health outcomes. It's not okay. So we have to be about the business, and what the pandemic opened our eyes to is that everything is possible. Frankly speaking, We cannot accept anymore that, well, this is not done or it's not, but no, it is possible. When we come together and we put the investment and the money and we put aside whatever sort of manufactured false division, divisive processes are, and we are about the business of saving lives, we can do it. So I completely agree with the commenter's observation that we had those examples because there was funding for it, because there was attention being made to it, and that it showed, it was proof of concept that we can make a difference if we start to sort of act outside of our silos and work across sectors. So we have to be about the business of advocating for the change in sort of our healthcare models to incorporate faith-based leaders and other community leaders, community health workers, etc., so that we can actually move the needle when it comes to health outcomes and actually resolve the health disparities that we claim that we don't want to tolerate anymore. So I'm supportive of that. And at Wayne, we do have strong relationships with local faith-based leaders for many years. And they've been critical, I put those in the chat, in terms of working with folks on the ground to address hypertension specifically, but other cardiovascular disease and getting those rates down. So I'm very supportive of faith-based leaders as critical actors in the work to actually address health outcomes and resolve them finally.
Thank you, Dr. Opara. And I'm afraid that we're at our time, and I have to thank everybody on our panel for their wonderful presentation, for the wonderful work that has gone into this, for the intersection that we see between all of our communities as part of Better Health Partnership. You know, we've been saying that for a long time, is that this is a combined effort, that this is going to take clinical work and thought and community work and thought and finding our middle ground and finding the ways that we can keep crossing these barriers. This is an important project. This is an important piece that people will look at in the future to say, here's an example of how we were able to make this work. And I thank everybody for their efforts. I thank all of you who have attended today. The wonderful comments, wonderful thoughts and questions, challenging. You know, we need to be challenged on a regular basis because obviously doing the same thing hasn't worked. So we appreciate your thoughtfulness and your participation today as always. We look forward to you participating in future webinars that we have. And I'm so happy to be able to say this, see you in the fall. But please join us anytime that you can, in any way that you can. Please come to the Better Health Partnership website. All the materials will be available for you. And we're all happy for your participation. Look forward to future meetings. Thank you.